Thank you for joining CareerCert today for our webinar focusing on a COVID-19 case presentation and complication EMS professionals cannot miss. I'm your host for the webinar, Danielle. At CareerCert, we are focused on providing emergency and healthcare professionals with the training they need to best protect and care for those in their communities. We are grateful for this opportunity to connect with you and to be able to connect with you who are on the front lines of the COVID-19 pandemic, to share this information that could make a life-saving difference in your community. It's my pleasure to introduce you to our presenters for this webinar, Paul Rosenberger, Gil Salazar, and Virginia Smith. Dr. Paul Rosenberger has over 30 years of EMS experience, with over 20 years of adult education instruction. He has performed ground and flight paramedic duties and leadership in town administration during his service. He has served as a faculty member and assistant program director for UT Southwestern. Currently, Dr. Rosenberger is the associate director of the EMS continuing education program at UT Southwestern and an adjunct faculty member for the Emergency Services Administration program at the University North Texas, Dallas. He is also the co-chair for the National EMS Education Standards Development Revision Team. Dr. Gil Salazar is an associate professor of emergency medicine at UT Southwestern. He serves as the medical director of EMS education and oversees both initial and continuing education of area EMS professionals. He practices clinically at Parkland Hospital Emergency Department. Dr. Salazar is dually board certified in emergency medicine and EMS and serves as core faculty for the emergency medicine residency and the EMS fellowship programs of UT Southwestern Medical Center. He is the creator of Campus Emergency Preparedness and Survival Training. His main goal is to improve the quality of education in the management of natural and human-made disasters. Virginia Smith is a licensed paramedic for Cypress Creek EMS in Spring, Texas, which utilizes aggressive emergency protocols, including whole blood in the field. She is currently completing training to serve as the in-charge paramedic position in ambulance teams responding to 911 calls. Virginia received her bachelor's in biology from Texas A&M and her master's in biomedical science from the University of Incarnate World School of Osteopathic Medicine. Virginia is a medical school applicant and hopes to be accepted and start medical school fall of 2021. Virginia's training has included medical care in wilderness settings and rural poverty in Latin America, where medical resources are limited. For those of you who would like to earn free CAPC accredited CE hours for attending this webinar, you will need to attend the entire webinar and complete the assessment we will distribute following the webinar. We will send the assessment to your email within 24 hours after the webinar finishes. Once you complete the assessment and provide us with your license number, we will automatically report your CE hours to CAPC. And now, I will go ahead and turn the time over to our presenters today.
Good morning. My name is Paul Rosenberger, and today we're going to talk about COVID-19. We're going to introduce a patient with potentially having COVID-19, and then we're going to have a nice discussion on this particular case. Today's objectives are listed here. First, we want to review the relevant pathophysiology of COVID-19. We want to describe the proper EMS assessment of COVID-19, discuss typical and atypical patient presentations in the setting of COVID-19, differentiate between respiratory, vascular, and neurological emergencies in patients with COVID-19, analyze a differential diagnosis in COVID-19, design a feasible management algorithm for patients with atypical and typical COVID presentations, and finally formulate an EMS destination decision-making plan for patients with COVID-19. So with that, I'll introduce Dr. Salazar.
Good morning to those who are still in the morning time zone. Good afternoon to those of us farther east than you, and hope everybody's having a good lunch. If you're having some lunch, please go ahead. We're gonna discuss a case today. I was personally responsible for this patient. We're gonna talk about several concepts today, which we hope you find very useful. Please be sure to ask questions throughout the scenario. We'll be monitoring the chat pretty closely. And if you have any questions or concerns after the webinar, please feel free to drop us a note. A big thank you to CareerCert for partnering with us on this offering. We think that this type of information can be potentially life-saving, and we think that those EMS professionals out there taking care of these people deserve the greatest and the best education when it comes to COVID-19. So without further ado, let's go ahead and get started. We have changed some of the aspects, some of the details of this presentation to protect the patient's identity. Let's get started then. So dispatch call comes in as a sick person, altered mental status. The crew is made up of 2 paramedics, and the history obtained is that we have a 76-year-old gentleman. Family states if he's not been acting like himself. He's been lethargic for approximately the last 3 hours. And of note, prior to getting there, they find out that the patient is in a flagged home, living in the same household as a COVID positive patient. So this sparks a little bit of conversation right off the bat, and I want to pick up Virginia's brain as to kind of what's your approach with this? What's your mindset? That's been one of the most difficult things for me. It's kind of the mindset when you know you're going to be walking into a situation where COVID-19 is a possibility. What do you think, Virginia?
Absolutely. Well, if we have in the call notes that we know someone in the house is COVID-19, we have to assume the patient is. And so we would put on the proper PPE. For us, that includes eye protection, gloves, and an N95 mouth. We also do a 6-part interview before approaching every patient. And so that would be the same with this patient.
I imagine most EMS agencies in the world have a similar protocol. One of the things that I've found along the way is your differential diagnosis needs to stay really, really tight. And at the end of the day, it's still emergency medicine. So let's move on and give you a little more history about this patient. The medics are communicating directly with the family. The patient is able to provide a little bit of history, but the family is giving the majority of it. We know that he's had really no fever, no shortness of breath, no cough, no other really infectious types of symptoms. They first noted him to have some difficulty speaking approximately 3 hours ago. They assumed maybe he was too tired. He hadn't slept well, but the problem persisted, so they called 911. His past medical history is positive for diabetes. The family states the patient is compliant with his metformin. His last dose was earlier on that day, and he's got no allergies. So Paul, let me pick on you now. I have my kind of list of things that I want to take a look at, and my differential diagnosis. What's going through your head if you're assessing this patient?
Sure. So I'm a longtime paramedic, and so I love to use mnemonics. And so because we have a patient who has an altered mental status, I think the first mnemonic that I want to use is the mnemonic of AEIOU tips. And so just because this patient has some COVID findings in his home and an altered mental status, I want to make sure that I know exactly what's going on with this patient here. So, so using AEIOU tips, I'm going to try and rule out some things that could be potentially causing this emergency. So the A, of course, is acidosis. And so as we gather history and we do assessments and do vital signs and things like that, I'm going to look for sources that could be causing acidosis in this patient. The E is epilepsy. And so there's nothing here to indicate that this patient has an epileptic history, but we do have a diabetic history here, which could potentially be causing a seizure. So that's something that's credible here. The I is insulin, and again, we've got this history that this patient does have a history of diabetes. The O is being overdose, And so I guess we could inquire about any chance that this is an overdose type patient. The U is underdose, and so perhaps this patient's not compliant with his medications. And so we want to ask questions related to that. The T being trauma. So we want to see if there's been any type of traumatic event that has occurred to this patient, whether he's had a fall, struck his head, or anything like that. The temperature, is this a hyperthermic emergency or hypothermic emergency of some sort? Infections, so we want to inquire about past infections. And again, we've got a COVID-19 positive residents here. The P being a psychiatric emergency of some sort, so we could inquire about that and see if there is a psychiatric event going on here. And then the S is either a stroke or even a septic type event. So my differential at this point is really wide open because there could be a lot of things causing the altered mental status that we're seeing. And I think as we go through the scenario, we'll narrow that down a good bit. But right now, I'm wide open to a lot of different emergencies that could be occurring.
Yeah, absolutely. We, like most agencies and hospitals in the country, I think most of us have adopted a focused and limited physical exam. I think our poll reflects that. Virginia, before I give you a little more information, where do you sit on all of this? Limited, full exam, or load and go?
I do a full primary assessment for every patient, and so that includes listening to breath sounds, that includes a version of a shell, that includes touching the patient on every patient to kind of get a full idea. No matter, even if their complaint is somewhat minor, I want to do that full primary assessment on every patient.
Sounds like about 60% of our attendees are doing a limited and focused physical exam. So with that in mind, let me show you a little bit about the findings that we had. The medics noted, documented the patient was tachycardic at 110, his pressure 101/64. The family stated he normally runs more hypertensive than that, generally in the 130s, but he was managed strictly with diet, and that seemed to have adequate control of his blood pressure. Low-grade elevated temperature, not exactly fever. They did note that he was tachypneic at 24 and an SpO2 of 90%. And adding on to Paul's AEIOU tips, mnemonic, that O should include hypoxia. They got a end-tidal CO2 per protocol that was 33, a normal blood glucose. They checked pupils. Those were okay. Normal, clear lungs. They checked a radial pulse, which was just positive for tachycardia. They did a cursory neurological exam, documented the patient was alert and awake, oriented to his name, who he was, what time it was, what year, where he was, who the folks around him were, and also kind of what the situation around the household was. He knew that one of his sons was COVID positive. So Virginia, what do you think at this point? To me, it's getting pretty interesting. Where's your mind going at this point with this patient?
Well, obviously the first thing that jumps out is that low saturation of oxygen, and that's something that I can fix right now. And so I would do exactly that. I would do a nasal cannula at 40 liters per minute, see if that improves. With the not acting themselves, I would perform a stroke scale. And so just to see what that looks like and continue to monitor as the call goes on. Do you want to bring out your point about the ECGs at this point?
Yeah, let's see what the medics were doing. And one of the things that we were interested about in the management of this case is the question whether or not an EKG was indicated. For some agencies, the low to SAT would be more than plenty. For some, it's got to be some active chest pain, other type of kind of cardiac history. This patient really had none other than the SpO2. I'd be really curious what you all thought and also what our attendees think. So go ahead and take a look at the poll and tell me what you think. Paul, where do you sit on the argument? EKG, no EKG, and shortly we will see why this is a crucial part of the case.
Yeah, I think one of the things that, I mean, the age alone is a reason for an EKG, but the fact that this patient has a heart rate of 110, one of our mentors, Dr. Ray Fowler, always teaches us that we've always got to be able to explain why a patient has a tachycardia. And so we now have a 76-year-old patient with a heart rate of 110, and we need to figure out why that's the case. And so as the case unfolds, we'll certainly have an explanation, but right now my concerns are this heart rate of 110 and this O2 saturation at 90. And the really nice thing is that this blood sugar is 117. So this is probably not a diabetic event.
Looks like most of our friends watching the webinar agree with you. And even though this agency's medics, their EKG protocol is relatively loose, they went ahead and did one. Let's see what else the medics did on this call in terms of interventions. They chose to do some basic things on scene, started the patient on a nasal cannula at 4 liters, and I'll make kind of a brief note that some agencies are going straight up to just mask for protection. The O2 saturation went up to 95%. They started a line fairly quickly. Now they chose to get the patient to the hospital. In Virginia, you were dead on. They were concerned enough. They did a stroke scale right off the bat. No facial droop, no slurred speech, and the patient had no pronator drift when they checked. And they did do an EKG. So Virginia, I'll let you have first crack at it. Let's see what it looks like.
Absolutely. So here I see normal sinus rhythm. Rate is about 75. The QRS looks nice and narrow. It's not wide. I like that. And so there's nothing that is super concerning at this point. If you do look at lead 3, it looks a little weird to me, but nothing that I can necessarily call at this point. So I'm probably just gonna watch it on another one later. So this does not have ST elevation, SEMI, any of the major concerns as of right now.
Yeah, it's definitely a little on the fast side from where I can see it right there. Definitely agree with you. The morphology of lead 3 ST segments is pretty abnormal. I would like to call your attention to a couple of things that jumped out at me on the initial EKG. You see those ST segments and 1 AVL and also V2, V3. They're kind of sad, kind of droopy. They don't have a nice morphology. It's not nice and tight. And then you see a little bit of elevation there on the more lateral leads in V5 and V6, particularly V6. And so I'm wondering at this point, when I looked at the EKG, if we might have been dealing with an infralateral process. Definitely didn't have a prior to compare it with, but certainly kudos to the medics for getting an EKG right off the bat and recognizing there was a problem. So, okay, well now we have a gentleman with an abnormal EKG with some altered mental status, and now we're on our way to the hospital. Let's move the case along a little bit. I'd like to tell you kind of what was the next step on there. Approximately 2 minutes before arrival, the medics noted the patient was more lethargic. They told me that the patient started reaching for things outside of the stretcher onto the floor, invisible things that were not there. That caught their attention. They had the presence of mind to recheck a blood glucose at the time. That was normal. They were still concerned about his neurological status, so they got a stroke scale going again. This time, they described it to me as babbling, definitely not a normal speech that he had before, and he definitely had left arm weakness. And that was a brand spanking new finding. So now, at this point, you are 2 minutes from the hospital, and let's assume just for argument's sake, the hospital you're going to is not a stroke center. Virginia, what do you do if you're going with this patient and you're 2 minutes away? the
I
hospital
changed
you're going
directions and
to
go
for
to
stroke?
the stroke center. That's what this patient needs.
Gotcha. Yeah, I agree with you. Paul, any thoughts?
Oh, I think just for argument's sake, I'm going to say that we need to go to a cardiac facility because we have a patient with a tachycardia, ultramental status, potentially some EKG changes, and now we got a patient who's reaching for objects and having some difficulty speech and some weakness. And so, man, we got a train wreck going on here. And but I think just I'm going to be ornery here, and I'm going to pick the cardiac facility instead of a stroke facility.
Gotcha. You know, in that EKG, if you want to look at it very, very kind of by the rules, doesn't necessarily mean doesn't meet STEMI criteria. But I tell you what, I'm gonna think long and hard about that EKG if I'm a medic looking at this patient with active symptoms. But now you got a neurological deficit on top of it, and then I gotta put on my physician hat, and I want to wonder what can a PCI center offer versus a stroke center, and the medics had a really hard decision at that time. Thankfully for them, this center was a stroke center, and the decision then was fairly easy. But if you don't have that luxury or those resources, that's going to be a tough call. Looks like our friends watching today think almost half and half go for this stroke center. So it sounds like that EKG caught the attention of a lot of you. So that's pretty cool. Well,
Yeah.
let's see where we
Yeah.
proceed.
The nice thing is if you're in an urban or suburban center, you probably have a facility that can manage both emergencies. But maybe in the rural or the frontier areas, that's not going to be an option. So a lot to think about right here.
Yeah, I mean, are you gonna fly this patient? You're probably gonna have to if you don't have those types of resources in an urban environment. So at this point, the medics are at the bay. They do activate the stroke protocol, and the patient goes off to CT. Now, one of the things that we've been kind of looking at is that I'm very glad that we saw in this case was just the vigilance of the medics when it came to assessing this patient so closely before they got to the hospital. We're actually conducting a study, and we looked at some data to kind of support the concept that period between patient arrival at the hospital by EMS to when they're delivered, that's one of the most dangerous times for patients. Our good friend Dr. Ray Fowler has looked at that. So kudos to the medics for that degree of vigilance. The patient was rolled to the scanner, and as you can see there, I mean, you don't need an advanced degree in radiology or anything to see that MCA stroke there on the right side, which completely correlates with the symptoms the patient saw. And to me, it's just very impressive that so quickly after the symptoms started, you can already see those CT changes right there. That's a pretty devastating effect. So now you have a patient that is COVID positive, and now it's got an acute right middle cerebral artery infarct. So at this point, the patient is in the scanner. Patient gets transferred to the emergency department bed, and all of a sudden his saturation drops to 57%. We know that the patient needs some airway management. Virginia, I want to kind of pick your brain a little bit without diving too much into intubation or anything. Like, what is your kind of current protocol on airway management for somebody like this?
Absolutely. If his O2 stats are 57 in the field and we can't get them up by just normal oxygen or other airway procedures, then yes, that would be a intubation right away.
Are you doing full bunny suits, just N95, mask, gloves, the whole shebang?
We have goggles, and then we have these face masks on top of the goggles, and then we have full gowns and gloves, obviously masks, and Yeah. So we're completely covered for any aerosolizing procedures.
For sure. In this situation, we were in a more controlled environment and pretty much got everybody out of the room. So the patient got intubated under very strict and controlled circumstances. So he got intubated. A repeat EKG was done, and this time let's see what we have. So this time you see more pronounced changes in the inferior leads. You also have some involvement in the lateral leads as well. So that EKG is definitely shows deterioration for the patient. So now we have a patient who is presumably more than likely COVID positive with an acute MCA stroke, and now you have a STEMI. That's a pretty sick patient. So Paul, at this point, I welcome some of your thoughts, some of your expertise. I mean, we'll discuss kind of what happened with the patient. What are some thoughts that you have?
Well, I mean, this EKG is showing us in leads 2, 3, and AVF. We've got some elevation going on there, and so we have a embolic event here that's involving the brain, the heart, and probably other organs as well. And so again, I think the best destination, kind of to close the loop on that, is to go to a destination that can manage patients who have myocardial events as well as patients who have stroke events. And again, in the urban centers, that's going to be an option, but in the rural and the frontier communities, that may not be the case here. And so that's kind of what I see. So we're dealing with a patient with a MI and a patient who's having a stroke here, and so we're just going to have to move to a facility that can manage both conditions.
Yeah, Virginia, does this EKG sway you at all? This one compared to the first one, or you're sticking to the stroke center first?
I mean, if you don't have a hospital that can handle both, that's a really hard decision. I'm lucky that I have hospitals that can handle both in my area, so I'm lucky I'm not have to choose. But honestly, like between stroke and cardiac, if both of these were presenting, I think I would still do stroke, but I guess you would not be wrong just making a decision and sticking with it.
Gotcha. Now there are some thoughts about this specific patient. Now he's 76 with both an acute ischemic stroke and evidence of myocardial ischemia. So some of the decisions that we're going to be making in the hospital, if the medics give me this history pre-hospital and I inherit this patient, I'm going to be thinking about, goodness gracious, what am I going to do first in terms of anticoagulation? And that is part of the reason we wanted to discuss this specific case, because it's not so clear cut in this specific population. And it turns out it's not that he was really unlucky and that he developed these three things, but he was really unfortunate in the fact that he developed one of the most feared complications. I've personally never seen this type of pathology before, only read about it until now. So before we move on to a little more discussion, let me tell you a little bit about kind of what we did for the patient after the EKG and kind of his hospital course a little bit. He was admitted to the unit, to the ICU very, very soon after arrival. He was upgraded to critical very quickly. Some anticoagulation took place in the hospital. Some heparin was given. The decision to give him TPA, thrombolytics, was a very tough decision. He didn't really meet criteria for it at the time. And so the hospital personnel upstairs chose to go with just some systemic anticoagulation with heparin. But the patient died within 24 hours of symptom onset. So his deterioration was really fast. He goes from talking and being alert and awake with a negative stroke scale to dying within 24 hours. Just on a personal note, to me, it was pretty sad having to talk to his wife about how quickly things deteriorated. You know, they were okay that morning, and then the next day he's gone with really a bad disease process. So let's discuss a little bit about kind of the meat of the webinar here and see what kind of points we can bring. And so, as I said earlier, I had only really read about this in anecdotally and case series, but it wasn't until this gentleman that I got the opportunity to see firsthand really what COVID does. So let's move on to the next slide here, Paul.
Do you want to discuss why this person wasn't a good candidate for TPA, or do you want to do that on the next slide?
Yeah, let's do it on the next slide. Definitely something that I wanna discuss for sure. Let me give you a little bit of background first without sounding too much like a lecture. And Paul and Virginia, I welcome your insights too. One of the things we started learning fairly early on in the pandemic was just what a massive inflammatory response COVID-19 causes in the body. So it's really an excess of fighting molecules like cytokines, for example, IL-1, IL-2, TNFs, for example, that just ramp up our fighting response in COVID-19. We don't have the innate immunity against this specific virus, or our body goes into ramps up for fight. And one of the deleterious effects of this fighting response is that we create really a bad inflammatory response, leading to both hypercoagulability. We increase our chances of clotting, and also the lining of our vessels, of the endothelium, also sustains quite a bit of damage. And that combination is indeed a deadly one. So you start seeing a lot of thrombotic events throughout the body, and it's my personal belief that this patient was suffering from exactly that. So soon after you get that thrombus, that clot burden going, it's just a matter of time before you get tissue hypoxia in your brain, your heart, and your kidneys, and it's really difficult to bounce back. Some of my colleagues in Seattle, very early in the pandemic, got really sick, specifically because of this type of inflammatory effect in the body. Some of them needed to be on dialysis and other really advanced critical procedures to keep them alive. Thankfully, the majority of them pulled through. But what a bad combination of items to have.
So there's a lot of information on this slide here, Dr. Salazar. And I have a question about I guess it's a yellow box that says local and systemic inflammatory response, or SIRS. So would you call, as a paramedic, should a SIRS activation be activated, a code stroke, or a code STEMI by EMS? And again, it kind of factors into what destination should be selected as well. So lots of things going on here to kind of kick around. As a paramedic, where do I go, and what's the alert that I use for the hospital?
Fantastic question. You know, for the majority of systems that do have kind of an alert for SIRS or sepsis, it's mostly for an infectious type of process, and COVID-19 is indeed an infectious process, but most of the time when systems have such a system is for bacterial infections, and the purpose is to get antibiotics started as soon as possible, significant volume resuscitation started. So it's a really good question. Does this patient meet SIRS criteria? He was tachypnic and tachycardic. He would meet SIRS criteria. Does he meet alert criteria for sepsis? We do have an infection, so that equals sepsis, but it's not really a bacterial one. So I think the decision to activate pre-hospital is mostly going to hinge on the effect that this inflammatory response is having, namely the stroke or the STEMI, because you're going to have to individualize the decision to anticoagulate somebody or what other treatment. Are they going to go for a heart cath? In our patient, the decision was made to not take the patient for a heart cath, where we go in with a catheter from the groin or your radial artery and try to retrieve kind of clots that could be blocking your coronaries. And really the reason that is just this is a different type of thrombus, different type of clot. Patients with myocardial infarctions, the ones we all learn about in school, tend to be from plaque, platelet aggregation. This one tends to be more from that endothelial damage, from hypercoagulable state, and so it may not be amenable to heart cath. And certainly this patient was not a good candidate for that.
And perhaps that's the reason why he didn't get the TPA.
Yeah, exactly. The other portion for these patients, they're so tenuous, Paul, that the TPA could also be catastrophic for him on the other end. Could we go the opposite direction and actually have a bad coagulopathy where they bleed a lot? I don't see that often in COVID, but certainly the decision to TPA these patients is hotly debated in this situation. It wasn't just systemic anticoagulation. Virginia, anything jump out at you in this slide?
Yes, absolutely. Can you go a little bit more into the pathology? Can you explain what the cytokine storm is?
Yeah, just like with every disease process, especially infection, severe disease, these patients mount a really powerful inflammatory response. As a matter of fact, one of the treatments that most of us in EMS are learning about now is the use of steroids, like dexamethasone, for example. It's more than likely because it's helping curb this massive inflammatory effect on some patients. Now, in some patients, like some of my colleagues in Seattle that I was telling you, the inflammatory response is so severe that they can have multi-organ failure, etc. And some of these patients actually need kind of higher level immunomodulators. So where you see things like hydroxychloroquine or Plaquenil, or some of the anti-rheumatoid arthritis drugs that help curb this inflammatory process. So yeah, this cytokine is among the group of cells that ramp up this inflammatory response and help us fight. But it's pretty pronounced in COVID-19.
Well, if an EMS agency has steroids that they carry and protocols for them, would you suggest using that in the field, or would you suggest waiting for the hospital?
That's a remarkable argument to have. I think that some patients are going to benefit from steroids, but those criteria need to be really well delineated. Right now, even in the emergency department, we are kind of taking these decisions very, very carefully, and not every patient is started on dexamethasone unless they meet certain criteria like bad respiratory symptoms, ICU level care, for example. So some of these patients are receiving steroids, but I think that decision cannot be taken lightly. Additionally, I think if you have non-judicious use of steroids, you really run the risk of, we are seeing national shortages, and I'm sure our viewers or participants at home may be having to deal with shortages in dexamethasone, which many folks rely on for kind of your run-of-the-mill respiratory illnesses and other inflammatory processes besides COVID. So, but if you're an EMS agency and this is something that you're thinking, I think it has to be that consideration needs to be taken very, very carefully.
Dr. Salazar, Can you address, I see down here in the bottom, this macrothrombosis and the microthrombosis. What does that look like and what does that mean to EMS? I see the macrothrombosis is the pulmonary emboli. I'm assuming it also has to do with the stroke and the myocardial event here. And then the microthrombosis is the ARDS. Can you talk a little bit more about those?
Yeah, this bad inflammatory response, what's so dangerous about it is that, it does affect both large and small blood vessels. So let me take you a little more globally. Our big blood vessels, we know what those are and we know what they're capable of, but these smaller blood vessels are also responsible for other things like circulation in your vital organs, and not just your brain and your heart, but also say your kidneys. And so it's no surprise that when you start attacking your smaller blood vessels with microthrombosis, then you're going to start seeing effects in some of your other organs that are also going to take a beating. So one of the interesting findings so far in COVID-19 is that these patients are going into dialysis not on an infrequent basis. So many of our patients that do come in very, very sick by EMS, or they walk in the door already with respiratory symptoms, some of them get intubated. That degree of inflammation is so severe that they wind up getting intubated. They wind up needing things like dialysis, and other folks even extracorporeal tissue oxygenation or ECMO. And so the degree of thrombus and clot formation at different levels of your vasculature, of your blood vessels, is very, very pronounced. Now, let me make the process even a little more scarier for you. So with this patient, we remember that he was tachycardic, low SpO2, and a respiratory rate of 24. If you were just looking at it from a COVID perspective, it might be ARDS, acute respiratory distress syndrome, mostly affecting the lungs and sometimes flooding the lungs with fluid. But now you got another process like a pulmonary embolism that could be responsible for that as well. And personally speaking, I have personally already diagnosed several patients who have COVID-19, no other risk factors for pulmonary embolism, and they come in, guess what? Low SpO2, tachycardic, tachypnic, and now we're a lot more vigilant because a good chunk of these patients are walking around with pulmonary embolism as well. Virginia, have you taken care of anybody in cardiac arrest yet, suspected or confirmed COVID-19?
Yes, there's not suspected, no confirmed yet. We have to use our PPE, the gowns, the face masks, everything, and we still treat it like a normal cardiac arrest.
One of the scariest prospects for me is that I wonder if some of these patients that we were seeing in cardiac arrest in the early phases were dying, not just from STEMIs or strokes, but also pulmonary embolisms, and we never even knew it. Some agencies tightened up their processes for calling patients in the field, termination of resuscitation in the field. And so I wonder how many of these people, how many of these patients were actually having pulmonary embolisms.
Absolutely. And it's scary to think about that even just shortness of breath that seems to come with COVID could be something very serious like a PE.
Dr. Salazar, how does DIC play into this?
Yeah, disseminated, excuse me, coagulopathy can, in many disease processes, including bad infection, can occur. So this is a process in which you have this deadly fluctuation, these ups and downs in coagulation. So they can be hypercoagulable, at times hypocoagulable. And that is certainly one of the dangers in COVID-19, though my personal experience in that in the literature so far is mostly the hypercoagulable state. The other end of the spectrum is also a possibility and equally as deadly. And once again, the treatment may it kind of complicates things a little bit when you're making decisions about anticoagulants and things like TPA. I want to address some questions here in the chat. A 15 lead EKG available not for this patient. Fantastic question. I can tell you that a bedside echo showed no dysfunction of the right side of the right atrium. So definitely a great question to ask in any patient with infralateral changes on their EKG. Coag studies, these patients are receiving kind of a battery of tests that includes things like D-dimers, for example, that help us assess the patient's risk for thrombus formation, etc. And we note that some of these markers are elevated in patients with COVID-19. Now, yeah, so there's a question about DIC, those that are kind of getting better. That's so really what you guys are asking is a patient had COVID, thought I was getting better, and now is sicker. Could that be a presentation of DIC? Yeah, absolutely, you can. Let's see, let's take a look at the next one. Virginia, you want to tackle the next one?
The pseudo-STEMI question, or which next one are you referring to?
There is one that says, can we discuss the patient with a CVA, particularly a bleed CVA that has a STEMI indicative of 12 lead? How many of these are STEMI versus a pseudo STEMI, as in troponin is not elevated? Have you heard of that concept before?
I have heard of that. That would be something to consider, that maybe the CVA is kind of causing the elevation on the ECG, and at this point, I think that would be some blood tests to determine that for sure, and that would be the hospital. So definitely be quick on scene, but do everything that you need to be doing for this patient. I don't know with this patient, what do you think since you received this one?
Yeah, the high intracranial pressure that you can get with hemorrhagic strokes, with bleeding strokes, can cause an EKG pattern that resembles that of a STEMI. Haven't seen that in the COVID era before. Certainly before, it's the real deal, and it can throw you for a loop. And I've actually read case reports of unfortunately patients getting anticoagulants for this type of stuff with a catastrophic effect, just because it can cause significant EKG changes reminiscent of a STEMI. The patient's D-dimer on this one, it was above normal. It was 3.5 times the normal, and that is something that we pretty much universally expect in patients with symptomatic COVID-19. Now, for those of you who are interested in this type of stuff, D-dimers we utilize pre-COVID to assess for certain things, including your risk, your likelihood of having a pulmonary embolism, though we found kind of in the COVID era that it can be elevated, and now it's making sense to us exactly why. Just because of this really bad inflammatory response that's taking place in both the macro and micro thrombosis that takes place. So this patient's D-dimer was about 3.5 times that of normal.
Okay, well, we're at 12:49, and so can you just kind of summarize this table on the right here and kind of give us some pointers as EMS providers as to what we can do to help these patients and get them to the right destinations?
Yeah, most definitely. I'd be happy to. Just a couple of things to remember. These inflammatory cells lead to both a hypercoagulable state where you become more prone to clotting, and then endothelial damage. Both of these things combine to cause clotting, both at the large vessel level and a small vessel level, leading to tissue hypoxia, especially in the heart, brain, kidneys, and lungs. And you can see some catastrophic effects of this thrombosis, namely ischemic strokes, myocardial infarctions, pulmonary embolisms, acute kidney failure. In one of the presentations for bad lung tissue diseases, acute respiratory distress syndrome, ARDS, in which these patients, this happens a lot in flu as well. They develop a bad respiratory illness. They need positive pressure, both pre-hospital and in the hospital, and they're very, very sick patients.
And kind of brings me to a thought about paramedic initiated refusals. You know, with what you're presenting to us today, it makes me very scared to have a patient or a paramedic initiated refusal. Any thoughts on that?
The era of COVID taught us a lot about kind of rethinking some of the things that we were doing before. Let me put a brief scenario for you. You run on a patient who has a COVID positive contact at home. They may have very minor symptoms, perhaps mild cough, mild headache. Their vital signs are within normal limits. They have no comorbidities. They're young, otherwise healthy. And so pre-COVID, a lot of agencies have kind of refusal criteria to no load these patients. Now, after COVID, with everything that we're learning, it does make me quite a bit nervous about what that cough, what that mild shortness of breath, what that mild headache may be hiding. So a lot of agencies, including here in our very own area, have revised these protocols so that there's really an entire checklist of things that need to be kind of considered before you even consider no loading a patient or getting an informed refusal. And so, but that decision is going to be very tough, and I urge all of our participants at home to be very cautious of that, because those minor symptoms could be really the presentation for something, a manifestation of something really, really catastrophic. Not to scare anybody, it's just a reality of everything we've learned in COVID, and it's a humbling experience. It's the real deal, and it makes you rethink medicine as a whole. Let me throw it back to you guys.
And I think a good point with that is that this patient that we presented at the beginning was not a good candidate for two reasons. One, because of his age, he was elderly, and his SpO2 saturations, which would automatically make him not a candidate for a PIR, or some people call it a COVID non-transport, whatever your agency would call it. And so that's very important to know the checklist and to know what would disqualify this patient for being a non-transport.
And I think you're going to see, good point, Virginia, and I think you're going to see folks that are legitimately worried. Well, they may be scared because they ran into somebody who was COVID positive. And you're definitely going to run into those folks. My advice is exactly what you did, is take a very hard look at everything regarding the patient's presentation. Take everything with a grain of salt, and just remember that this is a vastly different process from what we see on a day-to-day basis. Everything is COVID right now, and COVID has these catastrophic consequences. And so I just urge you to kind of take a second look at things when you're thinking about refusals. Follow your clinical guidelines to a T, and be very careful in taking care of that patient and taking care of yourselves.
And so it's now 12:54, and I think, Danielle, we were going to leave this open for a few questions.
Yeah, so are there any last questions that people want to add? Feel free to send them in or send them into the chat, and we can go ahead and tackle any of those right now.
If our participants out there are interested in UT Southwestern doing some more of these with CareerCert, please give us that feedback as well and what you thought about all of this. Your feedback is really invaluable to us. We want to be of good service to you, and please let us know what we could be doing better, or if you want to see more or maybe even less of us.
Okay, I have one question that just came in. If you thought that an ECG showed MI, but with a COVID HX, could myocarditis still use aspirin and NTG?
Yeah, absolutely. Myocarditis is one of the things that we're seeing. Fantastic point to our participant who brought that up. Myocarditis is an inflammatory reaction in the tissue of the heart, and you can see that after many viral infections, particularly some other disease processes, but definitely the real deal in COVID. And so the findings in myocarditis can be EKG changes. Some of them may look like STEMI. So it is perfectly okay to start aspirin and nitroglycerin, certainly, for sure. Aspirin has been shown to help this inflammatory process in myocarditis, and you're certainly helping to start that process earlier. So definitely a fantastic question, definitely.
Looks like we had one more question come in. Oh, so some people are asking if this will be available as a recording to view in the future. And yes, we will have this recording available. You can view at any time. It will be on CareerCert.com. We have a tab for webinars. So if you go to CareerCert.com/webinars, you can be able to view it there. We'll also send out an email right after this finishes with links to the webinar and the video. Feel free to share that with anyone on your team or in your community who you think could benefit from this information.
And kudos to whoever brought the question about disseminated intravascular coagulopathy, DIC. Definitely a good one for this type of format.
Well, thank you so much.
Yep, I'm just scanning for any last questions. Oh, here's one. Have ER responses to potentially COVID patients changed your management in the field?
Have ER
responses to potentially COVID patients changed your management in the field?
I suppose the question is, have kind of hospital practices changed the way I manage patients in the field? If that's the spirit of the question, yeah, absolutely. PPE for one is something, to be very honest with you, that sometimes pre-hospital we're not great about. And I'll be honest with you, I wasn't always the best in PPE, maybe a little too cavalier, both in the hospital and pre-hospital. My mind has been swayed the opposite direction for forever and ever. So definitely I've taken those practices kind of within the hospital to the pre-hospital arena. Some of the equipment that we use, particularly bunny suits, are now a more acceptable part of what we do pre-hospital as well. Some of the things that I would like to see in the field more are intubation boxes. We're doing few aerosolizing procedures in the field kind of as a whole, but I would like to see better protection for our EMS professionals out there when doing these procedures.
Perfect. It looks like that's all the questions so far. So thank you so much for your time today and for presenting on this needed topic. We're so grateful that we could have all of you as our presenters and that you could share your expertise. And we thank all of those who attended for joining us today for this important conversation. We would love to continue the conversation with you, and please visit us at CareerCert.com to access this recording or for other free resources to help you be at your best so you can best take care of the patients in your community. And again, if you are hoping to earn CAPC accredited CE hours for attending this webinar. Please complete the assessment that we will send to your email within 24 hours after this webinar is finished. And we will go ahead and automatically report your hours to CAPC. Thank you again, everyone, for joining us today. And we're so grateful that you took the time to tune in. And we are grateful for your sacrifice you make to make your community safer places. So take care and stay safe.